Now, health authorities around the world are on heightened alert as the latest Covid-19 Omicron subvariant BA.2.75 or the Centaurus is at its, as it is called rather, is spreading rapidly globally. It's now been identified in 10 countries, including India, Australia, New Zealand, Japan, United States of America, United Kingdom, and Germany. The World Health Organization says hospitalizations have doubled and in many places across Europe tripled since the variant struck 6 weeks ago. Experts are warning that super-infectious offshoots of the Omicron variant have been driving the new wave of diseases across Europe. Joining us now to discuss whether South Africa should indeed worry are Wits University's Dean of Health Sciences, Professor Shabir Madhi, Stellenbosch University Epidemiologist, Dr. Joe Barnes, and International SOS Global Health Advisor for Clinical Governance, Dr. Chris van Straten. Good evening to you, and thank you very much for your time and for joining us tonight here on In Focus. I suppose the latest report of the Minister of Health also having contracted the virus and currently in isolation at home trying to recover has certainly brought this question back to our minds as the country has moved towards gatherings again, mass participation events, and have dropped some of the previous limitations and restrictions that were in place. But Professor Madhi, let me begin with you. Is COVID still rampant in the population?
Good evening. Thank you for having me. So certainly in South Africa right now, we're not experiencing a resurgence. In the Northern Hemisphere, there's many countries that are experiencing a resurgence. But that resurgence, in fact, is not driven by BA.2.75, what you refer to as Centaurus. That resurgence currently is being driven by the BA.5 variant. Now, the BA.5 variant and the BA.4 variant, which is very similar, the last resurgence that we experienced in South Africa were due to those two sublineages of the Omicron variant. And what we experienced with the last resurgence was a wave that was substantially subdued compared with anything that we had experienced in the past, even less so than the BA.1 Omicron wave that we experienced towards the end of last year, which itself was substantially less severe than the preceding wave due to the Delta variant. So what's happening in North America as well as in Europe right now is more driven by the BA.5 sublineage of the Omicron variant, which is sort of a cousin of the Omicron variant, rather than this BA.2.75, which is showing an increase, but at this stage certainly is not dominating. Should we be concerned in South Africa? The reality in South Africa right now is despite modest vaccine coverage, less than 1/3 of the overall population, we've got 90% of people that have developed immunity, and that immunity has largely been driven by infection, together with some vaccine rollout. And the combination of that two puts us in a relatively favorable position in that even if something like Centaurus or BA.2.75 does enter into South Africa, we still probably got good protection, at least when it comes to severe disease and death. We can do much better. We can do much better if high-risk individuals, people above the age of 55, 60, especially those with underlying medical conditions, get boosted doses of vaccine, be it even the third or the fourth dose, because neither infection-induced immunity or one or two doses of vaccine is adequate in those high-risk individuals. So that is where our focus needs to be.
Yeah. Dr. van Straten, as Dr. Professor Madhi puts it, it's the BA.4 and BA.5 that is largely driving the kind of infections that we are seeing in the UK in particular. But what has been noted, though, is that even if people had a past infection or are fully vaccinated, people are still catching this particular infection. So can we rely on South Africa's current vaccination rate, but even the natural immunity that has been born out of people just being merely infected?
Excellent question. And first off, just big thanks to Prof for his fantastic guidance over the last months and 2 years as we've been navigating. This is the country, but also the global academic community. So BA.5, and that is exactly right. We had that wave, small wave in April, May, and not as big as we had kind of expected. And we're seeing it now. Like in America, we're seeing the numbers climb steeply with hospitalizations, with a 30% increase in cases just in the last week. So in South Africa, we think that some of that, as Prof has said, we had about 1/3 vaccinated, which is good, but we can do better, and we must do better. And then we think a high number of people got infected during the Delta wave, which means that as South Africans, we've got a lot of antibodies. Yes, we are seeing some immune escape with BA4 and BA5, but I think we do know this from what we're seeing, the data coming out of some of the countries like the UK and the US. It's still significant protection from severe disease and death. And again, that emphasis on my concern is for the at-risk individuals, people who are frail, immunosuppressed, people someone who's pregnant. We want to make sure that they are vaccinated and boosted. And I'm still washing my hands and I'm still masking up. Why? Because I want to protect myself and others. And it's a tough call. The politicians, we don't want to be restricted again. But I think we need to be smart and be wise. We've had 2 years of battling this pandemic. I've had a friend say today, but I thought it was over. It's not. And we still need to be smart and wise about what we do. Thank you.
Yeah. Dr. Barnes, a slight reduction of effectiveness of vaccines on variants, is that a conversation that we are having in South Africa? Are we concerned about that at all? As I've seen, for example, in the UK, in Los Angeles and other parts, they are beginning to be having this conversation as to maybe we need a different kind of booster vaccine that will now respond to these new variants.
Good evening to my colleagues and to the viewers. First of all, I would like to say that whatever subvariant or sublineage we are talking about now, this is still a COVID-19 virus and people can still get ill from it. Even though it may be clinically less severe, it is still not an illness to play with. It is not just a common cold. And it certainly isn't over, and I'm so grateful to my colleagues for stressing that, because talking from a community health point of view, I'm very concerned about the lack of energy and interest from the authorities about getting vaccinated, getting boosted. The information campaigns that ran over the last year or more reduced itself to orders: get vaccinated, wear a mask, wash your hands. There's no explanation behind that. And then they come out and say, well, use your judgment or your common sense. For the ordinary person in the street, they have to base that judgment on what? On what knowledge? Because there's so little extra information made known. So that's one of my major concerns, is that along with the hype from the media that said it's Freedom Day, we need not wear a mask anymore. I'm deeply concerned about that, because working in community health and in the dense settlements, as I have been in the last 30 years, you want to get those people back to wearing a mask if suddenly something with green tack is pitches up and they are much more dangerous than the ones we've seen before. People are not going to listen. Yeah. So my concern is every time there's a dip between waves, the happy assumption that this is now over and we can go on with our lives, the lack of attention to air quality, simply air replacement in all sorts of public buildings. I've not heard of a single meeting talking about air ventilation, which is a great help in combating that. There's been no attention about ordinary safety measures, and there are plenty of places in South Africa with not enough water for people to wash their hands. Yeah. So we really need to do our homework a lot better. But thanks to my colleagues for stressing that.
Yeah. Professor Madhi, we seem to have thrown out the initial COVID-19 playbook, which I know to an extent you were quite critical of it, particularly around the surveillance that we were doing, the kind of testing that was being conducted and its effectiveness. Are we at a point where we need to assess or reassess maybe where do we go from here in terms of how we are going to deal with this going forward, in terms of imagining what it means to live with the virus?
Yeah, so I think the important thing is whenever you're doing testing, you need to be goal-directed. You don't just do testing as a bean count. There needs to be purpose behind your testing. So in the context of South Africa, the reality, unfortunately, is because of the limited scale of testing as well as issues related to access to healthcare and willingness of people to come forward for testing, we've identified less than 10% of all of the infections that have transpired. So we don't do quarantine. We're no longer doing isolation for all intents and purposes because the majority of people that are infected are unknown to us. So in the absence of doing quarantine and isolation and contact tracing, there's very limited value to be testing at a community level. You need to be testing certainly where it's going to influence patient management. So as an example, people that are going to end up in hospital or high-risk individuals that might complicate. You're wanting to know upfront whether you're wanting to intervene at a different level in those individuals. But we do still have good surveillance in South Africa. It doesn't mean that we're no longer testing in a community that we don't have good surveillance. In fact, right now, what the indications are is that there is more virus transmitting in the community. Looking at our wastewater surveillance, there seems to be more virus has been detected. And also the National Health Laboratory Service have got different type of surveillance, which also shows an increase in the amount of virus that's circulating. So there is sort of probably the beginning of another resurgence, which probably will be relatively small. But we do have surveillance in place, which enables us to make informed decisions on how to react when there is another resurgence. The other important issue, and you raised the issue about vaccines, unfortunately the reality is that the current generation of vaccines don't do a good job in protecting people against being infected or developing mild COVID, but they do a marvelous job when it comes to protecting people against severe disease. And the same thing goes for past infection. It doesn't protect too well in protecting against infection and mild COVID when there's a new variant or a new sublineage that circulates. But at past infection in the majority of individuals performs really well in protecting against severe disease. The two combined, infection plus vaccines, what we refer to as hybrid immunity, induces the most potent immune response. And you probably get protection against mild COVID as well as severe disease. And that's good reason enough why people still need to be encouraged to be vaccinated. But at the same time, we can't be diffuse in who we target for vaccination. We need to be goal-directed again. The priority in South Africa is protecting people and preventing hospitalization and death. That is a priority. And to achieve that priority, we need to get 90% of people above the age of 50 vaccinated foremost before we start fiddling around trying to get children vaccinated when children simply are not at high risk of developing severe COVID.
Yeah. And Dr. van Straten, what is the thinking now? For example, it's summer in the UK, and they were, of course, about getting ready for mass participation events and celebrations and the likes, because also the kind of thinking earlier on was that this would be a winter flu like kind of situation. That kind of thinking is changing now. COVID is not thought of as seasonal. What is the thinking now about it going forward?
That's a bit of a challenging question. I think Prof. Joe Barnes said it nicely earlier too. It's not the common flu. First of all, just the virus itself, right? And then the other aspect is we're 2 and a bit years into it, but we've seen waves and we've seen so many variants coming along with BA 2.75. By the way, I just need to say this because it's interesting and also a little amusing. One of our interests is misinformation and disinformation. And Centaurus is the name given by someone on Twitter when they first spotted the name. So someone randomly on Twitter went, I name you Centaurus, and now it's named Centaurus. So BA 2.75 is in 10 different countries. It's got a lot of mutations, which is why the WHO has flagged it and we're interested in it, but we don't yet know what those mutations are going to mean. And we keep saying this, it's a bit of a mantra, but it's really important. The more people that are infected, the more variants we're going to see. And if we keep on having wave after wave, you can't say at the moment this is a cyclical annual event, because flu tends to be seasonal and track with the winter months. This is wave after wave with a couple of weeks in between. And this significant spike now, especially in parts of Europe, Portugal's kind of tapering and dropping off a bit, but we're seeing in Germany, we're seeing in the UK, significant rise, and again, hospitalizations. I'm weary to say, okay, well, we've got it in a box, we know how to deal with it, and we're moving on. I think we're still needing to figure out quite a lot, and I just want to reemphasize the basics. Prof has said it, Prof Barnes, Prof Madhi. We need to consider the basics, and it's simple things: hygiene, masking, vaccinating, and when you can or needed, get boosted. Thank you very much.
Yeah. Dr. Barnes, 65% of those who are being tested and certainly who are testing positive in the UK are reporting a sore throat as the most reported symptom and headache and a blocked nose maybe next. But does that tell us anything at all?
You know, one of the problems if I'm much more lowly than my two colleagues. I work in the streets and in the shacks. So it's very difficult for people, particularly if they don't have a lot of education and not a lot of information coming into their lives from all sorts of media, to distinguish between the common cold, a flu attack, and the start-up of COVID. By the time they get very ill, they try and access public health facilities. And we've just heard today that the public health facilities in the Free State are literally collapsing. So and if I can borrow a phrase from Prof Madhi, which is so telling, we need to be goal-orientated. And we need to make sure that from the health services point of view, from our population information point of view, that we have our ducks in a row, and that people know what they're supposed to do, and that there are facilities for them to do that. Access to healthcare is an art and an unaffordable luxury for some people. They don't even have the taxi money. So we really need to try and get the basics right. If I can repeat myself, get people to be able to not have 60 people to a toilet, which means a lot of crowding and a lot of contact between people and surfaces that are never cleaned at all, and massive other challenges of other infections that are putting them, and poor nutrition that are putting them under such pressure that they are sitting targets for something that comes around like that. This has been a huge finger pointing to us, all of us, to do better, as Prof Madhi said. And I'm concerned that it gets yesterday's news if something else replaces it. Like monkeypox, we need to learn lessons on how to handle outbreaks of all kinds, and I don't see a lot of motivation for that in the present system.
Yeah. Speaking of doing better, Prof Madhi, you mentioned we need to be goal-directed, particularly when it comes to vaccination. Should we push for another round of boosters, particularly for those who are at risk?
Absolutely. That's the singularly most important thing that we can actually achieve something that's of meaning. To vaccinate high-risk individuals, like I said, high-risk individuals by now should be getting a third, if they're not their first dose of vaccine. And that would probably be almost everyone above the age of 60 in South Africa, as well as anyone else with any other sort of medical condition, including obesity, including diabetes, any cancer patients, as an example. If they haven't received the vaccine in the past 3 to 4 months, now is the time to get a boost dose, not when we're in the midst of another resurgence, because you're wanting the protection, you're wanting that immune system to be prepared for the next resurgence. So now is the time to be focusing on those high-risk individuals and getting those additional doses of vaccine. And for people that haven't been vaccinated, like we've said, like everyone has said on this interview, COVID is not going to disappear. People are going to remain vulnerable, and the best way to protect themselves is to be vaccinated, even if they've been previously infected, and especially if they are at high risk of developing severe disease.
Dr. van Straten, and when we speak, of this mildness of this particular variant, it's almost as if people think, oh, well, it's mild, it has got no consequences, maybe even on the pressures on the health system. One of the things that they are picking up, of course, in the UK, that even if it is mild, but, one bed that is occupied is one bed that could have been occupied for some other more maybe severe disease at this particular point.
Yeah, exactly, and it's nicely put. By the way, Eric Topol, he's a well-known scientist in America, said it very nicely in the last week. He was saying, we know that some of the Omicron subvariants appear to be, let's say, less severe, so more infectious, but perhaps less severe in terms of disease. But however, some of that, what needs to be taken into consideration is if you're fully vaccinated or you had previous infection, well, it might appear less severe. So remember, that can muddy the water a little bit. But even if it is less severe, it's still not a disease you want to get. And the reason I'm saying that is a couple of things. Remember, we're focusing now very much on the acute. Oh, I got sick. Do I end up in hospital or not? But increasingly, we're seeing this discussion around long COVID. And it's, in some ways, there's not an absolute definition yet, but in essence, we're seeing more and more people with symptoms months after being infected that include fatigue, joint pain, this thing called brain fog, and the repercussions of some of that can be quite severe and debilitating. And in fact, in the UK, for example, there was a 15% increase in the previous 2 months related to reports of people with symptoms and signs of long COVID, and that's going to have a significant impact on people's ability to function, to work, and for businesses. So I don't want to get COVID, not just because of my risk of hospitalization and death. I don't want to get COVID because I do not want another mutational being part of that. I do not want to infect a family member or somebody I know who's potentially high risk. And I do not want to run the risks of potential long-term complications and what that might mean for my life and all the lives of others. So I think it's important, it's sometimes hard, but there's a bigger picture that we need to step back and look at and go, it's not just about those hospitalizations and the beds being full. Yes, that's critically important. Yes, we can't, hospital systems can and will be overwhelmed. And we've seen that as these different waves have come through. But there's a bigger picture too that will impact us physically and financially. Thank you very much.
Dr. Barnes, on those streets, in the lowly streets of South Africa, you're beginning to see cases of long COVID, and how severe are they?
We've seen an interesting upsurge, sad, interesting upsurge in mental health problems that seem to, in quite a number of cases, be linked to neurological effects of long COVID, as they've said, and it's yet another burden. The mental health services in South Africa is the one aspect of the public health services that are the most severely underfunded and understaffed. They're facing a wave of people with difficult to define vague symptoms, as Dr. van Straten said, and they're really continuously overwhelmed because long COVID doesn't make waves; it is just there all the time. There's just another point that I was wondering about, and my colleagues will be able to help us out there. Young people are very loath to get vaccinated, and they have the confidence of youth, and it's not going to happen to them, and if it does happen, it's not going to be severe. But they get it, and they aren't severely ill, but they bring it home, and then granny ends up in the intensive care unit. So even though they're not severely ill, they can still pass it on pretty efficiently. And that is where I would like to be able to motivate them, inspire them to also not only think of themselves, but think of those that they can pass it on to.
We'll continue in a moment and get some closing remarks and points there from our panel. But let's take your views as well. 072-110-5584, or you can tweet us tonight at Newsroom 405. Are you concerned at the return of infections, particularly being reported in the northern hemispheres of the world? Stay with us. Back with you tonight, Channel in Focus, Newsroom Africa, Channel 405. The conversation continues. We still have with us Professor Shabir Madhi, Dr. van Straten, as well as Dr. Barnes, helping us in the conversation tonight. Prof Madhi, I know with the challenges that we're currently facing with electricity, with now reported inflation, the jobs that were lost and so on and so forth, people were quite eager and quite in a hurry to get us to open, and maybe rightfully so, one would even argue, depending on where you are sitting. But was the return into mass participation events thought out well in terms of what we needed to put in place before we began to scale up in these kind of participations?
So I think it goes, the bottom line is, what do we know of COVID and what can we expect of COVID? And COVID is not illness that's going to disappear. The virus is going to be with us for the rest of our lifetimes. So this is not a virus that's going to disappear. Yes, over time, the type of resurgences that we experience will become less frequent and of a lower magnitude and cause even fewer number of people to end up in hospital and die. The chances of the virus mutating to the extent where it's able to evade that arm of the immune system which protects us against severe disease and death is extremely slim. If that does happen, it takes us back to March 2020. Now, the reality of all of the regulations that existed in South Africa is that unfortunately they didn't work at a public health level. Because had they worked, we wouldn't have had 90% of the population infected with the virus at least once. And in fact, with the Omicron wave, what we showed in the study in Gauteng is that just in that single wave, 60% of people in Gauteng were infected. Just in that single wave, when we still had mask mandates, when we still had restrictions on indoor gatherings and everything else. So in a South African context, believing that we can actually prevent all infections by having high levels of restriction and having types of regulations which are people simply don't adhere to it, and the material conditions doesn't allow them to actually adhere to many of those regulations, becomes a futile exercise. And all that it achieves is that it creates harm to the economy, it creates harm to the livelihoods of people. So we need to reflect on what we have achieved, and we haven't achieved too much when it comes to preventing and protecting people from being infected. And we are now in a space, as we mentioned before, where there is substantial protection against severe disease. And that should guide our decision-making as to how to respond next. What we can't afford to do is continue setting aspirational goals, which comes at an opportunity cost. An opportunity cost I'm referring to is a huge number of other challenges that we face, not just in health, but also in the economy, in the social well-being, in the mental well-being of people. Those are opportunity costs that we can't risk continue bettering, because what we face with is we need to reprioritize now and focus on those priorities which are very real in South Africa. When we talk of COVID-19, it's surprising that people don't in the same breath speak about a number of people that are going to die and more number of people that are going to die of another illness in South Africa, which we've had now for more than a century, and that is tuberculosis. The number of people that are going to die of tuberculosis this year in South Africa would far exceed the number of people that would die of COVID. The number of people that aren't being adequately managed for their cancer because of disruption of healthcare services is things that we need to start figuring out how to what remedial action is required, rather than putting all our resources into a single basket to try for an aspiration that we will fail. We are unable to prevent infections, but we are able to protect against severe disease and death, and that is where the focus needs to be. So I don't believe that we lifted the regulations too soon. In fact, I think we left it too late, because all indications were already towards the end of last year that the Omicron wave was going to be substantially less severe than anything that we experienced in the past.
Yeah. In terms, Dr. van Straten, of what we have achieved, reflecting on that particular point, have we achieved a degree of understanding in our workspaces? Because a lot of people are once again beginning to work from the office, when we had thought, of course, at the time that technology would now allow a lot more people to actually work from home. But, of course, the situation in South Africa doesn't allow for that. But also, more people are beginning to use public transport once again, because there's just no other option. With petrol going up and so on and so forth, that is the only mode of transportation that would get people around. But have we gotten around to thinking, how can we make those particular spaces a little bit more safer?
Excellent question. And the answer is yes and no. And Prof. Barnes made a very good point. And it hasn't been widely in the media, but I have seen some research on it, and some institutions trying to implement this in different regions of the world, and that's ventilation. So we know that if you have good ventilation, remember over the last 2 years, you have heard that thing, if you're going to gather outside. Why? Good ventilation. So businesses are starting to increasingly have that discussion. I think there needs to be more of it. And certainly in public spaces, whether that's public transport, whether that's big offices, we can still do active things. So it's the kind of ventilation. In hospitals, we use types of filters called HEPA filters, which allow filtration of these different organisms and viruses. There's been research too into different types of UV light. Not applicable for all places, but Prof spoke about TB. And there are wards in South Africa, TB wards, that have been using that kind of devices for some time and with good effect. So the answer is there needs to be more, and it needs to be, as Prof Madhi outlined, pragmatic. We have to continue with our lives. Business must continue. Economies need to continue growing. But we have learned a lot of the 2 years. We've got a lot more tools, but we also need to be wise, and we need to, one final point I would like to make is the WHO has put a lot of effort into misinformation management. And in the different countries and regions, they're focusing on, one, finding the source. Who's creating the misinformation? How do they benefit from it? And then trying to make sure that we are communicating to our communities in a way that's simple, effective, and giving them the tools to say, okay, this is the logical next step I need to take. And in South Africa, we've got the NICD, they've got a fantastic website where I as an individual or a layperson can go and access the current numbers. The WHO's got fantastic websites and information that lay people can access and go, okay, this is how it works, or this is what I need to do. And the Africa CDC has also been keeping up, running data and recommendations. So it depends on your level, depends where you're functioning, but we need to take all these different tools that we have been using and testing and bring them together wisely under the guidance of people like Prof Madhi to make sure it's cost effective, to make sure it has impact, and it's goal-driven. Thank you very much.
Right. I'm going to get a view from Prof Madhi as well on this, but Dr. Barnes, let's begin with you. There's been, of course, a number of recommendations and talks around an antiviral pill, Paxlovid. Do you think this will help us beat COVID?
Sorry, the sound is not so good. An antiviral
pill called Paxlovid.
Well, it's actually not my part of the action, but I am in awe. I want to say in awe of how much enormous amount of research has gone on in the last 2 years. We have made bigger strides on this virus than we have made on the HIV virus for a lot of years, because we have so many more sophisticated tools. So I have no doubt that sooner or later we will get a lot better medications to help us with. But medication from a community health standpoint will always be, let us almost say, a last resort. we first need to try and avoid as much of this as we can. And my big passion or request would be for everybody who has had a lot of experience in this, both the critics of the government and the friends of the government, to get together and sit down and note what worked, what did work, or what worked somewhat but had unintended consequences. We need to formalize these kinds of things, because sooner or later there's going to be another virus coming around with different aspects and different crises. We are in this for the long haul, not only with this particular virus, but others as well, so that we are better prepared. Unfortunately, with community health and public health, there's always an element, a very strong, powerful element called politics that are involved in handling these things, so that we can get the politicians better informed and on our side, so to speak, rather than see us in the health services as their enemies or their opponents. And I smiled to myself the other day and say, we ordinary folks, we recycle plastics, but the government recycles excuses. we need to get away from that outlook in life and see how we can formalize it, so that there are policies in place, sensible, pragmatic, workable policies in place when the next thing comes around that is a danger to us.
Yeah. Prof. Madhi, what do we know about this oral antiviral pill? Do we know enough? Is it the answer that is going to help us beat COVID?
It's certainly not the answer. So Paxlovid is an antiviral, and it's been especially effective in high-risk individuals where the treatment is started within 1 to 2 days of symptom onset, so at an early stage, and it prevents the progression of the infection to severe disease and hospitalization. And it's been mainly evaluated in high-risk individuals, and particularly individuals that hadn't been previously vaccinated. So it is more broadly used now, more widely used. It's not yet available in South Africa, but in the US and elsewhere, they're beginning to use it in other categories of individuals as well, but still focus on high-risk individuals because there's a shortage in terms of supply. What it does, like I mentioned, is that it prevents the progression of infection to severe disease. It doesn't do much. It doesn't achieve much when given to someone that has already been hospitalized. So that is its shortcoming, in that you need to initiate treatment fairly early. But unfortunately at this stage unavailable in South Africa, and probably won't be available at least until the first quarter of next year.
Yeah. Is that a function of availability, or is it a function of SAHPRA having not given it a thumbs up?
No, it's a function of availability and supply. So the supply needs to be increased. Pfizer, which is a company that produces it, is sort of allowing for generics to start to be produced, but there haven't been any takers that I'm aware of in South Africa that have been sort of licensed to produce the equivalent of it. And there is a shortage of some of the components, which is making it difficult to ramp up supply.
Prof, I appreciate your time and your intervention, Dr. van Straten and Dr. Barnes, as well, for coming on tonight and helping us in this conversation. That's where we'll leave it for tonight here on In Focus.